be moving shortly to our next session, which is a talk on approach to a patient of liver-limited oligometastatic rectal cancer by Dr. Rachel Cooper. May I request Dr. Suchandana Goswami ma'am, radiation oncologist at Apollo, Kolkata, to come over to chair the session and introduce the speaker. So I heard Rachel speaking about this topic first time back in 2016 when I was attending a course, FRCR Part 2A course at Tata Medical Center, Kolkata, and was thoroughly impressed by her presentation. And she has been my teacher, mentor, and guide while I was working in Leeds. Over to you, Suchanda ma'am.
Good evening, everyone. My task of introducing Dr. Rachel Cooper. She is the lead clinician for clinical oncology in Leeds Cancer Center, UK, and also the National Medical Director of Education and Training for the Royal College of Radiologists. Her area of interest is gynecological, colorectal, and anal canal cancers. Topic is approach to a patient or liver-limited oligometastatic rectal cancer. So I invite Dr. Cooper once again.
And thank you, Animesh and the organisers for inviting me to speak today. I will try and share my screen. I'm always not very good at that, but let's give it a go. And hopefully, has that come up?
Yes, ma'am.
Yeah, lovely. Thank you. So thank you yet again for that kind introduction. If my slides start to go a little bit slow, I'll just turn off my video. So yes, Animesh asked me to talk on this subject, and I did actually approach one of my colleagues, Natalie Casanova, I work very closely with, who's very much involved with the SABRE work, because I thought this might be an area of interest for her. So I'm presenting this really with their help as well from Natalie and Louise Murray, also at Leeds Cancer Center. So liver-limited oligometastatic rectal cancer is quite an interesting area. And up to date, I think we've just been feeling our way and really treating these patients perhaps pragmatically and using experience rather than any evidence base. We still don't have a great deal of evidence base, but increasingly we can gain information from trials and work that's been done to point us in a direction which I think is a good approach for these patients, potentially curative, or if not curative, giving them a longer disease-free survival. So I think before we dive into how we might treat these patients, we should all be on the same page with regards to what we mean by oligometastasis. And I think that's really, really important. And why is that important? Because I think we're all talking about something different. And a very, very simple, broad definition would be the intermediate state between local regional disease and polymetastatic disease. So a limited number of metastases. And I would suggest, and this is a classification from Hellman, and you can see the reference there back in 1995, that there are four broad subtypes. There are synchronous, so that's presentation with the primary cancer, and we'll talk about that in more detail. Now, when we say synchronous, do we mean at the same time, at the time of diagnosis, or within a very limited period of time? And some people would define that within 6 months. So again, there's some controversy there. Metachronous would be the development of metastasis after the primary cancer has been diagnosed and probably successfully treated. But again, there's no standard definition of what that interval would be. Oligorecurrence is oligometastatic disease, which develops in the presence of a controlled primary cancer. And again, what would be the difference between that? And then finally, oligoprogression. And this is really a new concept, but it's a concept that I think we're all becoming more familiar with the increasing use of particularly immunotherapy and also biologicals, where we're tending to see control of the cancer with progression in maybe one or two different sites. And I'm seeing that quite a lot in gynecological cancers. And I think we will start to see it in rectal and colon cancer with increasing use of immunotherapy for those patients with dMMR. And so I think that's a really important area for us to start to think about how we might manage that oligo progression. So I've summarised these, or I've taken this diagram, and this was given to me by Louise Murray, just to emphasise this sort of progression between oligometastasis, oligorecurrence, through to widely metastatic disease. And we know that a high proportion of patients who have oligometastatic disease will go on to develop widely metastatic disease. And that's probably because they already had micrometastatic disease at the time, which clearly we were unable to detect. In fact, if you do look at the literature, there are about 9 separate clinical states that have been identified. And I personally feel that's a real overcomplication. But I've included the diagram for you here with the reference if you are particularly interested in doing this. But I prefer to stick to those 4 broad, fairly simple definitions. In the UK, how do we define it? Well, we often say less than 5 and certainly less than 3 would be defined as oligometastatic disease. And if you look at a more European approach, the ESTRO-ASTRUS consensus statement from 2020, they came up with some very vague conclusions, really, if you do look at that paper. And there's no clinical data to support the maximum number of metastases or organs to define oligometastatic disease. But the consensus was it was somewhere between 1 and 5. So we've defined oligometastatic disease, hopefully, but we also now need to think about what might be resectability, because in terms of oligometastatic disease, we're still thinking about, can we cure this patient? And we know a high proportion of them we can go on to cure. And in most cases, we will be thinking about surgery for these patients, so liver surgery. Now, I'm very lucky in Leeds because I work in a centre where we have extremely active liver surgeons with a large liver surgical department, hepatobiliary surgery department, who are very keen on resecting metastases. And I think the more metastases in the more challenging places, they seem to get more, shall I say, not say happy about, but I think they like the challenge. So I think it's important to say that the definition of resectability will depend very much on what you can access in terms of surgical expertise. You are aiming for an R0 resection. There is no point in trying to partially resect a liver metastasis because we know that with an R0 resection, and I'll show you some data in a moment, survival approaches anything between 20 and 45%. With an R1 resection or an R2 resection, it's no better than palliative chemotherapy. And of course, you put the patient through an unnecessary surgical complication with surgical procedure with potential complications. I think most surgeons would say that you need to leave about 30% of the liver or more. And again, resectability will depend on the number, the size, particularly the location, and the number of segments involved. Of 50%, as I said, will develop more widespread disease within 3 years. And that is because we obviously clearly not detecting the additional micrometastatic disease. There aren't really any randomized trials. So there are a lot of single case series, which I've put on here. Now you'll see some of these are for lung and adrenal, but the top section is particularly devoted to liver. And I think what you'll notice is that on the whole, the data is supporting a 5-year survival of around about 50%. And that's particularly for those larger studies and larger centres. So whilst we don't have any randomised data, the single centre expert centre data consistently comes up with a 5-year survival of about 50%. So I think we can be very we can be quite honest with our patients that that's the sort of prognosis they're looking at with oligometastatic disease. But again, it depends very much on the number of oligometastases, the biology of the disease, and the resectability of those metastases. So clearly, that's a little bit, the surgery is a little bit beyond what happens when those patients arrive in our clinic. So we see patients who present with both a synchronous primary rectal cancer and synchronous oligometastatic disease, however we define that. And that will probably depend on whether the liver surgeons say they can resect the disease with an R0 resection. So how do we approach this group of patients? Well, I think we have to think about this very logically and think about both the primary and also the metastases. So I like to divide them up into 3 broad groups. There is a 4th group, but that's the group with really where we've got essentially unresectable, either rectal or liver disease, which we'll talk about separately. So we have a very rare situation, perhaps, where we have a primary with metastases, which are deemed resectable, but the primary has no high-risk features. When I talk about high-risk features, we're talking here about any nodal involvement, any extramural vascular invasion, or involvement of the potential circumferential resection margin or the mesorectal fascia. I think this is an extremely rare situation. And in that situation, you could potentially offer surgery to both the primary and the metastases, either synchronous or staged, and then go on to give adjuvant chemotherapy. And that would avoid radiotherapy in these patients where they don't need any radiotherapy for the primary. In reality, I think a lot of people would still consider total neoadjuvant treatment. And I can see that you're having a debate about that a little bit later on in the programme. So I've just tried to avoid that, a long discussion on that, but I'm going to come to that in a moment in relation to the next section. So for this group of patients with very early rectal cancer, no high-risk features, but resectable metastases, there may be a good argument to avoid radiotherapy completely, go straight to surgery for both sites, and then think about the addition of adjuvant chemotherapy, as you might do with, say, colon cancer. But I'd emphasize that's a very rare situation. I think this is the most common situation where we have a primary which is deemed resectable but does have high-risk features. So again, just to remind you, those high-risk features would be extensive T-stage, so T3B and beyond, nodal involvement, extramural vascular invasion, or the circumferential resection margin or mesorectal fascia, either involved or threatened, i.e. within 1 millimeter of the mesorectal fascia. In this situation, you know that you want to give some neoadjuvant treatment to both the primary and before you go on to treat before you go on to give for the patient to have surgery, sorry. And it's really a question of how do you integrate that neoadjuvant treatment into a situation where you know you've already got metastatic disease and you don't want to risk the progression of disease within the liver. Clearly, chemoradiotherapy is an option, but the issue I have with chemoradiotherapy is that gap between finishing your chemotherapy and then going on to surgery for the primary, where the patient is essentially untreated. And you could argue for the whole of that time they're untreated because the chemotherapy that we give concurrently with radiotherapy in that situation is of a lower dose, whether you use 5-FU or capecitabine, is of a lower dose than you would give as a systemic anti-cancer treatment. So I think that is something to think about very carefully. I think a much better alternative is to give short course radiotherapy, which we tend to use more in the north of England and Northern Europe. And then between the short course radiotherapy having the action on the primary tumour, so shrinking the primary tumour down to enable an R0 resection by the surgeon, you've got a gap in which you can offer neoadjuvant chemotherapy. And that will continue to treat the primary. And then following reassessment with CT and MRI, hopefully to go on to surgery, either as a primary, to the primary metastasis synchronously or as a staged procedure. I've put any role for adjuvant chemotherapy, and I'm just going to turn my camera because it's telling me my internet's a bit unstable. Any role for adjuvant chemotherapy, because we know that adjuvant chemotherapy in the setting of rectal cancer, having received some form of neoadjuvant chemotherapy, the data suggests that the benefit is very minimal. Now, this was a plan or a protocol that we use very much, particularly in Leeds, and as there are a lot of centres in the north of England, without much evidence to back it up. But we now know that there is some good evidence to suggest that this is a good treatment with improved outcomes for patients with high-risk rectal cancer. And that data comes from the most recent randomized trials in total neoadjuvant treatment and the Rapido. So the Rapido study randomized patients between chemoradiotherapy, followed by surgery, followed by adjuvant chemotherapy, or putting all of the treatment up front, short course radiotherapy, followed by chemotherapy, followed by surgery. So the experimental arm, which we know has shown to be improved outcome, would be the arm that we would suggest you would use in the situation of patients with oligometastatic disease. And so the protocols that we've been following, the evidence is really starting to catch up a little bit to suggest that this is a good protocol for patients, with evidence to suggest that this may improve outcome. And you'll notice in the experimental arm, all of the chemotherapy is up front, so they don't get any adjuvant chemotherapy. And that's why I would suggest that we don't need to use adjuvant chemotherapy. There's no evidence to use it in this setting. The other interesting point about Rapido is that it was a well-tolerated treatment. And patients, whilst they experienced a little bit more increased toxicity in the experimental arm, most patients went on to get surgery as planned with no difference in surgical morbidity. And you can see that there. So that's the situation for patients where the disease is resectable, both primary and metastatic, albeit that there may be some high-risk features in the primary, in the rectal cancer. But what about the situation where you have borderline resectability, either in the primary or in the metastases? And that's often more likely in the metastases. So in this situation, particularly if you have a young patient, good performance status and no comorbidity, you might want to think about putting a more intensive chemotherapy regimen at the beginning of their treatment. Now, there are a number of ways that you could consider doing this. And you could consider short course followed by IR-OX-MDG, so 3-drug combination, which is not something that we have tended to do in the past. But we now know that there are some data to point us in a direction of giving more intensive treatment for these patients up front. And that evidence is coming from the PREDIGE 23 trial. So the PREDIGE 2023 trial has reported at a very similar time to the Rapido trial. And again, whilst it's not looking at the oligometastatic setting, we can draw some conclusions from this trial to support how we treat these patients with very limited metastatic disease, whereas I emphasize, we're still aiming for cure. So in this situation, as you will see, the experimental arm, which is the lower one highlighted in red, intensified the chemotherapy. So patients received triple therapy regime, it was 6 cycles over 3 months, followed by chemoradiotherapy with a break of 7 weeks, surgery, and then in addition to that, adjuvant chemotherapy. And that was randomized, as I'm sure all of you are aware, against standard chemoradiotherapy, surgery, and then adjuvant chemotherapy. So it was the addition of the 3-drug combination intensification up front, which was the real key to this. And we know that the data from this trial, as with Rapido, has shown an improvement in outcome as well. So we know that for these patients with no metastatic disease, but high-risk features, rectal cancers, there is evidence to suggest that giving them total neoadjuvant treatment is of benefit. And we can say probably that we now have a regime that we could use in the situation where we have a patient with borderline resectable disease, good performance status, no comorbidity, who would tolerate this treatment. I have to say, having given patients both PREDIGE 23 protocol and the Rapido protocol, the latter, the Rapido protocol, is much better tolerated, even in patients who are really young, fit, with no other comorbidity. So I think giving the 3-drug regime up front is something to think about very, very carefully in terms of the patient's performance status. However, for those patients who've got borderline resectable disease, it's really a good alternative to be considering. And again, the report suggested that this treatment, the experimental arm, was pretty well tolerated. So I think we have now some protocols of how to approach synchronous metastatic disease in the rectal cancer setting. We can also think about what evidence we have from the colon cancer setting to suggest that giving chemotherapy up front is of benefit. And we know that the EROTC 40983 study randomized patients between preoperative FOLFOX and postoperative FOLFOX, and they showed an improvement in progression-free survival of about 7 to 8%, but no benefit in overall survival. Now, I think what this trial is telling us that whilst giving upfront chemotherapy, and this is, as I say, in colon cancer, may not improve overall survival, we're not doing our patients any harm. So what I wanted to emphasize is that idea of giving the short course and then neoadjuvant treatment in the oligometastatic setting is certainly not leading to those patients having progressive disease in the liver during that period of time that you're giving them neoadjuvant treatment. And I would mention that the EPOC study, as I'm sure all of you are aware, in resectable disease showed a worse progression-free survival for those patients who received cetuximab and were KRAS wild type. In addition, anecdotal evidence and now some increasing evidence from phase 3 trials suggests that the 3-drug regime, you can get the maximum effect in terms of shrinkage and control of the disease within the liver, leading on to potential resection. So again, if we draw on trials not necessarily directed at oligometastatic disease, we can use that evidence to really justify or at least confirm the protocols that we're using for these patients, more to ensure that we're not doing them any harm, as opposed to trying to justify any benefit from that. And that was just to suggest if you do have synchronous metastatic disease which is not resectable, then clearly those patients need to go down a primary chemotherapy route. In terms of the non-synchronous, how do we manage those patients? And this, I'm talking about rectal cancer, but we have very little data from rectal cancer. So again, we must go back to the colon cancer data in particular. And for most people would say that if a patient who's been treated successfully for their rectal cancer and then develops a liver-only metastatic disease, really the primary treatment would be surgery. So you'd be looking at trying to resect those metastases. If it was borderline resectable, then again, you'd want to consider some neoadjuvant treatment as you would do with colon cancer. What about the role of adjuvant chemotherapy then in that setting? If they've already received, if they've not received any previous adjuvant chemotherapy, and I think that will be a very, very small group of patients, certainly it would be something to consider. If the metastases develop within 1 to 2 years and practice varies and there is no definite evidence to point you in one direction, most people would not consider further adjuvant chemotherapy. Beyond 24 months, which is quite an unusual situation, you might want to consider it. And in those patients, you may want to give a further neoadjuvant treatment prior to their liver resection. We also need to now consider the implications of DMMR. So we know that about 15% of patients have a deficiency in their MMR. And most of those are sporadic, a small number are germline. Most of those occur in the MLH1, PMS2, but we do see smatterings of other losses of the MMR proteins. We also know there's an interaction with BRAF, and they have a poorer prognosis, and they can also indicate whether this is most likely to be sporadic or germline. But this is really important to know because we know that data from preoperative chemotherapy from the Foxtrot study that was in locally advanced colon cancer, for those patients who did have a deficiency in their MMR, they didn't respond to neoadjuvant treatment. So we really need to think about this in rectal cancer as well. So for those patients who have deficiency in their MMR proteins, with oligometastatic disease, where we might normally be considering some form of chemotherapy, we know that they're unlikely to respond. And in that situation, we are either thinking about giving them radiotherapy alone and then going on to surgery for both the primary and the liver if both are resectable, or we may want to start considering immunotherapy. I think this is a very, very grey area, but there are some data, as I'm sure all of you are aware, that are coming out to suggest that this may be a treatment for these patients. However, the duration of treatment and when you would want to introduce surgery is still something that's very much in the air. And I'm not going to go into this in any detail, but I think it's something that you need to be aware of. And we certainly should be testing our patients for their MMR status before considering neoadjuvant treatment. Just a final note on surgery, when to do surgery. We know that surgery is usually done about 4 to 6 weeks after their last cycle of chemotherapy. So you need to coordinate very carefully with your liver surgeon, particularly if you're not in the same centre. The data suggests there's no point in continuing chemotherapy beyond the point of resectability, as you just increase the likelihood of liver toxicity. And oxaliplatin and irinotecan have different toxicities in the liver. The data suggests about 10% of patients will progress on neoadjuvant treatment within the liver. So what are the alternatives to liver surgery? And in the last sort of 5 minutes, I just wanted to talk about these. In the UK, we have radiofrequency ablation. I'm not sure whether you have access to that from your centre. This is NICE approved, as is microwave ablation, but that's much more rarely used. It's reserved for those patients who are not fit for surgery or have very difficultly placed tumours with relation to surgery, often in a recurrence following surgery, which is difficult for further operation, or sometimes an adjunct to resection. So if they're a very small volume disease, which the surgeons can't resect completely. In terms of efficacy, recurrence rates are higher than those reported in surgery, but that might reflect the group of patients that are treated with RFA compared to surgery, i.e. they're a poorer prognostic group. Tends to be about 10% less. And there's a little bit of evidence to support the use of systemic anti-cancer therapy with RFA in the same way as I've been discussing in the surgical situation. There has been an attempt at one trial. This was a phase 2 study. It was a little bit of a messy trial, and it was actually stopped early due to poor recruitment. However, the data from that does suggest that there may be some benefit from the addition of liver-directed treatment, and that would be RFA in the main, although some of those patients also went on to get additional treatment, particularly surgery or SABR, for those patients with oligometastatic disease. But as I say, this was a small study and it was stopped early, and you can see the data at 5 years is relatively low patient numbers. What about SIRT? So that's selective internal radiation therapy. This is NICE approved in very, very limited settings. So there's been a trial in this, the Foxfire, Surflox, Foxfire global study. And this was patients who were chemo naive. They had non-curative liver metastases. They received chemotherapy plus or minus SIRT. And there was a better response rate in the liver and longer progression-free survival, but no improvement in overall survival. So SIRT really is reserved as a third-line treatment and has no real place in the treatment of patients with oligometastatic disease that is potentially curable. And then finally, I wanted to mention SABR. Now, again, I can see that you've got Ganesh coming to have a debate with you, which I think will be great fun on SABR. And this is where Natalie and Louise have helped, because I don't actually do the SABR treatment. It's very specialised in our centre to a small number of consultants. But we know that SABR does have a role in the treatment of metastatic disease to the liver, and in particular, oligometastatic disease. Again, how do we define it? So it's going back to the slide that I showed you earlier, and we would tend to define it as 3 or less metastases if we were considering SABR for these patients. And clearly, most of these patients will be patients who, for whatever reason, have been rejected in terms of surgery, or surgery is not felt to be appropriate. So the rationale for SABR, as you're all aware of, is to prolong is that prolonged survival has been observed in a proportion of patients receiving surgical treatments, both in the lung and the liver. And as I showed you earlier, that's around about 40%. So we think that a radical treatment may result in improved or prolonged disease control or survival. And as SABR can achieve a radical treatment to oligometastatic disease, as with surgery, we'd expect an improvement in outcome for these patients. We have very little data in terms of randomized trials. There are increasingly single center trials which suggest that there is an improvement in outcome for patients who receive SABR. But the SABR COMET study, which was a randomized phase 2 study, and that was in multiple cancers, so this was just not colorectal, and this was looking at SABR in a maximum of 3 organs with a total of 5 oligometastases, which were all amenable to treatment with SABR. And if you try and glean from this some evidence for its benefit in colorectal cancer, you can see that in the SABR group, there was about 14% of the total trial population had colorectal cancer, and about 13% were in the liver, but that is from all tumor sites. And they were mainly bone and lung. But what they did show that there was an improvement in local control with a median follow-up of 51 months. And there was some suggestion, both in overall survival and progression-free survival, that SABR, certainly in a mixed oligometastatic setting, played a role in treating these patients. So certainly for those patients with rectal cancer, particularly where the primary has been treated and resected, but for whatever reason, surgery is no longer appropriate for the liver disease, then there may be a role for considering SABR. And that was just to emphasize the results from this study. So really, to just put all that together, those patients who've got resectable disease, both in the primary, the rectal cancer, and in the metastases, we would consider the resectability of those, and we would be thinking about treating the primary and the metastases. And that would be a combination of radiotherapy or chemotherapy and some form of neoadjuvant chemotherapy. For metachronous disease, then we suggest that we treat these very similarly as we would do with colon cancer. And for those patients who've got unresectable metastases, we now know that there are a number of alternative treatments, with probably SABR and RFA being the most important and showing the most promise for these patients. And thank you very much.
Thank you, Dr. Cooper, for taking us through the whole spectrum of the disease and to touch each and every point that we need some clarification. Thank you so much.
It's a
In
pleasure.
spite of that, if someone has some questions, you may clarify.
Thank you, Rachel. Thank you for the excellent presentation. So I have a question. I know you do not do biological therapy, but having said that, so you mentioned about for resectable disease, whether it's primary or metastasis, role of biologicals, whether it's EGFR antibody or VEGF antibody, it's probably defined that it is not beneficial. But for borderline resectable patient, where you're uncertain about whether the patient would eventually become fit for curative intent treatment, whether you would refer the patient to medical oncologist for additional biological therapy on the top of chemotherapy?
Yeah, certainly. We know that the evidence for bevacizumab is probably less, but certainly the evidence for the wild type KRAS patients, for cetuximab or similar, there are data now to show that these patients should be considered for that. So definitely, Animesh, in the borderline resectable situation, we would be considering that for those patients because there's a high chance they may eventually go down the palliative route. So in that setting, you would want to give them perhaps the most effective palliative chemotherapy treatment up front. And then if they do become resectable, then clearly you would refer them on for resection. So yeah, that's an excellent question and a really, really good point to make.
Another question, Rachel, I'd like to ask, In a resectable liver metastasis, in an oligometastatic setting, in a resectable liver metastasis, would you offer patient saber over surgery? Is there any patient group would you choose giving the option of saver over surgery?
Yeah, so I think that's a really good question. And I think in the UK, as you know, Animesh, our hands are a little bit tied in terms of when we can offer saber. So patients presenting with synchronous disease, it's more difficult to offer saber. I think one, because of the evidence that we have to date, and two, just because of our setting. I guess though, I think over time, the data is going to come out to show that for some patients, yes, with limited, however you want to define that, as I said, and I think that is really the next step for me, not being an expert in saber, but looking at it. I think the community really needs to come together and make some clear definitions of what they mean. But for very limited disease, personally, I think saber is a great treatment. We have the equipment sitting there. It's a lot cheaper than surgery. Patients don't have to go through a surgical procedure. So yeah, clearly I'm a massive fan of radiation oncology. That's why I do the specialty. But I think that gradually that will what we think is the right thing to do will catch up with the evidence and what we're able to do.
Yeah. I think we have got one question in the chat box. Can we have that question open up? So we've got a question from Dr. Nikhil Gopi. In synchronous oligometastatic setting, how is the ideal sequencing of primary and metastasis-directed local therapy? I think you have explained that. Yeah.
Yeah. I mean, I personally, so really, pragmatically, we used to give radiotherapy, and then in that period where you're waiting for the radiotherapy to work, we give the chemotherapy. Now, that was just a pragmatic, eminence-based approach. There was no real evidence for it. But nicely now, Rapido and Prodige have actually justified and verified what we've been doing for some time. And I think there are lots of questions. I think it's a really good question, because I think there are still lots of questions in the air about this. Because if you look at Rapido, it is 18 weeks of chemotherapy, but most of the UK are actually giving 4, so they're giving six months. We're giving 3 months, so 4 cycles, based on the ideal data. But the ideal data is saying that 3 months of chemotherapy for the majority of patients, and I would say all patients, is as good as 6 months. So we've shortened that time, but does shortening that time give less time for resolution of the primary tumour? Is that really important in trying to get, say, a complete response? And then you may actually be able to avoid surgery in the primary. So I can't go into everything. I feel very strongly about this. So I'd happily come back and debate this, because I think that I think there are still lots and lots of questions to answer about total neoadjuvant treatment. But from an overall point of view, I think that's the way to go. Radiotherapy first and then chemotherapy. And for a small group of patients with really advanced disease, I think giving the triple therapy up front is probably the right way to go.
So we'll conclude the session. Thank you. Thank you very much, Rachel.